Hello, everyone. Thanks again for joining for the Rafael Medina subspecialty series. And today we have very special guests with us, Dr. Sullivan and Dr. Mansoor. And they both of them have been very busy, and it's been taking. I'm so happy to have them on with us to discuss a case which Nat, the chief resident from the program, has put together. And so I'm just going to and we also have Sam and Evan supporting us with doing the scribing and the teaching points. So I'm going to pass on the mic to Dr. Mansoor to introduce himself.
Thanks, Kucho. Well, it's great to be here with you guys. I'm Andre Mansoor, originally from Portland, and that's where I currently reside. And I'm a hospitalist, internal medicine trained hospitalist at Oregon Health and Science University, or OHSU. And I've known Pete for many years now. And it's great having, like a friend and a colleague like that to bounce ideas off of. And I think it's actually great that he and I are both doing the case today because it kind of mirrors what we do in real life. When I have an interesting case or, a case that I want to, talk to somebody about, Pete's always my guy. And so we're constantly sort of, like thinking about cases together. So it's really great. And I've known Nate now for a number of years as well. And actually Nate did a kind of started an internal medicine sort of a podcast of it. Well, it wasn't really a podcast, but it was just like an interest group where it was this sort of thing, case presentations on Sundays. And so we're all kind of used to one another, I guess, in this setting. So
That's awesome. Dr. Solomon, did you want to introduce yourself?
Sure. I'm also a hospitalist. I've been at Oregon Health Sciences since 1994, and both Andre and Nate were students of mine.
Oh, but that must be a treat to be able to discuss a case with your students.
Absolutely.
Nate, did you want to introduce yourself?
Yeah, I'll be quick. It's a little daunting to try and introduce myself after Dr. Sullivan and Dr. Mansoor here because I've worked with them for so long throughout my medical training. But I'm one of the chief residents in internal medicine at Oregon Health Science University as well. Very excited to do this. As Pete mentioned, I worked with him for many years, and as Andre mentioned, I've honestly worked with both of them as a student for the past probably 6 or 7 years at this point. So now that I'm jumping into my own career as an academic hospitalist at OHSU starting next year. It's fun and exciting to work alongside him.
That's wonderful. I do have one question for each of you, and then it could be the same one, or you could choose which one you want to answer. And the first one is, what's the most subtle yet crucial physical exam finding which you have picked up, which has changed the diagnosis? The second one is, what would you say is the most overlooked aspect of physical exam in modern medicine? I do know both of you have an amazing passion for physical diagnosis, so I just thought the icebreaker question geared towards that would be a fun one to learn from.
sure. Yeah, I don't mind starting off. So I would say to answer the first question, there are a number of them that come to mind, but I would say the hands are a really rich source of clues. And something like clubbing, for example, is really easy to kind of pass over unless you're specifically looking for it. And Pete has taught me many things over the years. And one of the things that he taught me was that you should anticipate in medicine. Anticipation is really critical. The eyes can't see what the mind doesn't know. So unless you actually go looking for clubbing because you have a hypothesis in mind based on the history and the rest of the exam, you are very liable to miss it. And that's something that, that Pete and I have picked up on in other cases that was missed before. Things like, patients with cirrhosis who have clubbing should immediately think of hepatopulmonary syndrome, for example. And a couple of those cases come to mind. And maybe I'll pass it on to Pete before circling back to the other question.
So, as you know from Andre, we're both big fans of the JVP, and I think the JVP makes a huge impact in most patients I see on a daily basis. I'd say it's probably the most important. We're also big fans of the cardiac examination, and I think you don't need to be an expert at being able to recognize every murmur that's out there. But if you can hear a murmur and you know that it's abnormal, then you can pursue it and figure out what's really going on. And Andre and I have found that to be really useful in a number of cases.
And then, Kuchel, remind me, the second question was about what aspect of the exam do we feel has kind of like atrophied over the years, is underutilized? Well, not to piggyback too much off of Pete, but I would say that the most obvious thing for me and probably for Pete too is the JVP exam. I mean, I think it's something that um, is really critical to us on a day-to-day basis. I mean, I say this all the time, but I would really not know how to I would feel lost in the hospital or lost as a clinician if I did not have that exam available to me. That undifferentiated patient who comes in with shortness of breath, the JVP exam is super critical to decide, is this the heart, is it the lungs, or something else? And so we use that all the time, and we see patient after patient where their neck veins are elevated, and this finding is missed or unappreciated. And so sometimes they spend weeks or months without a diagnosis, just because this particular aspect of the exam has atrophied so much in modern practice. So that would be my answer.
That's great. And if Sam, are you ready to share the whiteboard?
Kuchel, I think you need to make me co-host and then I will happily share the whiteboard.
Oh, yes, sorry.
So Kiara, I have to ask, since your last name is Camacho, we've got a very near and dear Dr. Camacho at OHSU. Any relation? I'm sure it's a common last name, but since you're both in medicine.
Sadly, no. Many of my patients ask me if I'm family member of like this boxer Camacho, but I also said no. So no for
Macho Camacho.
yeah. Yeah.
Yeah, Albert Camacho is the doctor that I was referring to. He's a cardiologist. Great guy, great doctor.
Wow, that's so cool. Well, I don't know, but who knows? Maybe.
Is everyone able to see my screen?
Yep.
Okay.
All right, are we all ready to get started? All right, wonderful. Well, I have the easy job here, which is just sharing the case with everybody. And so for our first aliquot, I'll share some information. The chief concern is going to be a 57-year-old woman with lower extremity swelling. And for her HBI here, she moved from Texas 2 years prior, so we didn't have any additional medical records. She had a recent ear infection 2 months prior to her presentation to the emergency department, was prescribed Augmentin with symptom resolution, began to experience lower extremity swelling 2 weeks prior, which did not resolve and prompted her to present to the emergency department. Alongside the lower extremity swelling, she noted brown, frothy urine during the preceding week. Other important review of symptoms, there was no orthopnea, no paroxysmal nocturnal dyspnea or PND, no weight changes, no recent fevers, but does endorse malaise and fatigue over the past 2 weeks and is otherwise negative. As for past medical history, as I mentioned, largely limited due to her moving, but she does report that she has a history of seronegative migratory polyarthritis, for which she's over the past 2 weeks had what feels like a flare and uses 800 milligrams of ibuprofen a day, and no other noted past medical history apart from this a recent ear infection that I discussed earlier. Social history, she's a never smoker, no alcohol, no drug use, and vitals on presentation, blood pressure of 158/68. Oh, sorry. I'll hold up for just a little bit. Yeah. Blood pressure of 158/68, heart rate 73, respiratory rate 16, oxygenation 100%. She was afebrile on presentation. And then just initial labs to throw in here. We'll have some more labs coming up. But initial labs, her creatinine was 4 from a baseline of 0.6 2 months prior. Her UA showed large blood, trace leukoesterase, and greater than 500 protein. And her CBC had a white blood cell count of 6, a hemoglobin of 9, and platelets of 275. She was admitted for an AKI to our service. And that's aliquot 1.
All right. Well, I don't mind jumping in here, and that was a lot of information, and we got parts of the history, we got parts of the exam in terms of the vital signs, and then also some labs as well. Maybe I'll just kind of focus on the history and then pass it off to Pete. So, hearing this story, one of the things that I really try to do early on in a case is I try to sort of identify some problem, whether it's a symptom or a physical finding or a lab abnormality, and sort of build a differential around that. And I think we have that here in the sense that we've got somebody with peripheral edema. And sometimes in some cases, I'll pick a couple problems and sort of build a differential around them and see where the overlap is. And then use it kind of as a Venn diagram in that sense. And is there a condition or some conditions that would present, with both of these problems? But, sticking to the history, in terms of peripheral edema, the way that I kind of approach that problem, like the 10,000-foot view is is it a kind of a hydrostatic problem? Is it an oncotic problem? Or is it some kind of capillary leak situation mechanistically causing the edema, causing the third spacing, causing the fluid to move from the blood vessels into the interstitial space? And so within the oncotic arm of the framework, that subdivides into basically two mechanisms, sub-mechanisms. One is if you have a decreased oncotic pressure within the blood vessels, allowing fluid to leak out. And then the other sort of secondary subcategory there is if you have an increase in oncotic force from within the interstitium that's pulling fluid from the blood vessels and into that space. So on the hydrostatic arm, that's things like heart failure, for example. It's things like cirrhosis or venous insufficiency or DVT. Those are the kind of the conditions that would lead to peripheral edema via increased hydrostatic pressure. And then, of course, within that arm, we alluded to this earlier, that's where things like separating intravascular status and extravascular status becomes really helpful. So Pete and I both always harp on this with our students. When you're talking about volume exam, we want to know what is the extravascular volume and what's the intravascular volume separately. Extravascular volume is indicated by things like peripheral edema, ascites, pleural effusions, whereas intravascular volume is all about the jugular venous pressure. And sometimes they're concordant and sometimes they're discordant. So for example, in a situation where you have extravascular volume that's elevated, but intravascular volume is normal or not elevated, that would be a good example there would be cirrhosis, generally causes that type of discordance between extravascular and intravascular volume. Something like heart failure or constrictive pericarditis would cause them to agree. So the intravascular volume and the extravascular volume are both generally increased in that situation. So that's kind of the hydrostatic arm, and then moving into the oncotic arm, again, the decrease in terms of oncotic pressure within the blood, the main oncotic player in blood is protein, specifically albumin. And we can, consider a couple of diagnoses there, especially one that might tie in with the frothy urine that we're hearing about. And then the increase in oncotic interstitial pressure would be things like myxedema or lymphedema. And then finally, capillary leak. Those are things like local trauma, insect bites, where bradykinin is released and causes essentially like leaking of the capillaries. There's a very rare condition called systemic capillary leak syndrome that's a zebra in that arm of the framework. But that's kind of where I'm at right now in terms of the history, is I'm thinking about peripheral edema and I'm mapping out in my mind the differential. And then I'm now armed when I go and I examine the patient or I go to ask them additional questions. These are going to be hypothesis driven based on that differential. So now I'm very interested in the intravascular volume. I'm very interested in, other features of the case that might push me in, towards one of those diagnoses or away from it. I've done a lot of talking, so I'll pass it over to Pete.
So I would completely agree with Andre when I was hearing the case with lower extremity swelling, again, thinking of a very broad differential. But things that really struck me in her history that would help us maybe focus on what's going on. She does have a history of autoimmune disease. And in real life and in conferences like this, whenever there's an autoimmune disease mentioned, it's usually playing a big role in the diagnosis. You mentioned the ear infection. So could there be a connection between the infection, immune response to the infection, or the treatment that then was causing some of the problems? You mentioned the urine. So frothy urine suggesting proteinuria, which we found out later is actually present. So there's quite a bit of protein in the urine on the spot check. There was also blood in there. So initially what I was thinking is, could this be nephrotic syndrome? So nephrotic syndrome from something like membranous nephropathy from an infection or from an exposure? Could it be an IgA nephropathy? Could it be post-streptococcal nephritis? And then when we heard about the blood, it sort of changed from a nephrotic to more of a nephritic picture where you've got blood and lots of protein in there. And again, trying to think of a nephritic process that would cause this. If you're going to tie in the autoimmune disease, certainly autoimmune diseases such as lupus could be playing a role here. She's not really in the right age group to consider that right off the bat. When you mention an ear infection, could this be a recurrent sinus ear process? And that would bring up things like GPA, granulomatous polyangiitis, that can affect both the renal tract and the respiratory tract. So I think what I'd be thinking right now is it clearly sounds like a nephritic process, and there is a differential for nephritis. You can narrow it somewhat by checking things like complement levels. C3 and C4 are generally lower in cases like this on the boards, and most often in real life when the patient has a number of conditions such as lupus, post-streptococcal GN, membranous, and cryoglobulonemic nephritis. Those would all be associated with low complement in the setting of nephritis. If the complement levels are normal, then the differential changes to, and the mnemonic I use for that is grave. So that would be GBM disease, so good pastures, RPGN, which is sort of a basket term, Alport's, which is much more common in young males, vasculitis, and again, the vasculitides I'd be thinking would be primarily ANCA-associated vasculitides, IgA vasculitis, those sorts of things. And then the last would be et cetera, which again is IgA-related disease.
Wow, that was such a rich aliquot and so much of learning from this. I've got to listen to this a couple of times to be able to get the juice out of it. And Nate, we are ready for your next aliquot.
Yeah, if anybody was wondering why I'm still hanging around these two after years, this is why. It's always so exciting to hear how they think through these things and run cases by them. You learn something new every time. Okay, I'll jump back into aliquot 2 now. This is going to be the physical exam and just some additional labs and imaging that we have. So for the physical exam, generally we have a well-appearing individual sitting comfortably up in bed. In terms of HENT exam, she was normal cephalic, atraumatic, had mild bowing in the nasal bridge, no rashes on her face or exposed skin. Her JVP, as both Andre and Pete had mentioned, which is very important, was estimated normal at 8 centimeters of water. No murmurs, rubs, or gallops were appreciated on physical exam. Pulmonary, her lungs were clear to auscultation bilaterally without any wheezing, bronchi, or rales. In terms of her lower extremities, I guess I'll just go in order. In terms of her abdomen, it was soft and non-tender, normal active bowel sounds. Next here we have neural. There were no focal neurologic deficits for her, and cranial nerves 2 through 12 are all grossly intact. In terms of lower extremities, as I mentioned, there was no rash, but she did have 1+ pitting edema into a level just below the knees bilaterally. And then in terms of additional labs and imaging, her micro came back just what we'd seen before with 176 red blood cells per high power field, with normal being less than 4, 31 white blood cells per high power field. Her urine protein to creatinine ratio was 1.68. Urine cultures were negative on admission and remained negative. In her renal imaging findings, she had a renal ultrasound with Doppler that showed patent renal arteries without evidence of hydronephrosis. And then non-specific increased echogenicity of the kidneys. Basically, it can be acute or chronic kidney disease, but it is non-specific. And I'll pause there to finish off aliquot 2.
Want me to
I'll
go
let
first,
Pete.
Andre?
I'll let you go first, Pete, since I went first last time.
Sure. Okay. So really not a whole lot surprising there, just looking at the overall picture. JVP of 8 is right around the normal range. So again, consistent with somebody who does not have congestive heart failure. Interesting, I've never seen, so in the H&T examination in the US, I'm not sure how it is where most of you are from, we frequently will describe the head as normocephalic atraumatic. To me, that's as though it's similar to saying the patient has 10 fingers and 10 toes. It's so common that our heads are normal, so there's no evidence of trauma. What I tell my students is that if the patient was unconscious, it's probably important to mention whether there are signs of trauma. And I think the normocephalic dates back to the time when we had a lot of congenital syphilis, which hopefully doesn't come back. But interestingly, there was this bowing of the nasal bridge. So what to make of that? To me, that is suggesting somebody with a saddle nose deformity. And again, going back to things that can cause saddle nose deformities, it would be something like GPA, somebody who is inhaling cocaine or another autoimmune disease called relapsing polychondritis that can damage the collagen. I wouldn't think it would lead to nephritis, but again, this is increasing the probability that it is a vasculitic process such as GPA that's causing this. No evidence of rash, 1+ edema, so not a lot of surprises there. We get a little more information from the urinalysis. There was no mention of casts. I'm not sure if they looked for casts, but again, lots of blood, some protein, but not nephrotic range. And completely appropriate to do renal ultrasound in any setting of somebody who has renal failure to make sure there's no hydronephrosis, but also looking for any obstruction of blood flow. And I will let Andre take it from there.
Yeah, that was awesome, Pete. And I think the second aliquot nicely complemented some of the conditions that you mentioned in the first aliquot. And it kind of just reinforces the way we practice, which is hypothesis driven, and we're looking for things specifically that you guys asked us a question earlier about things that might be missed unless you're specifically looking for it. Well, as you remember, Pete mentioned GPA in the first aliquot. So if you're thinking about GPA on exam, that's your opportunity to look specifically for this, saddle nose deformity, because you might otherwise totally miss it. So just going through the new information one at a time. And I guess the blood pressure was given to us in the first aliquot, but that's abnormal. And I always like to get a sense of what baseline is when I see an abnormality in a patient, whether it's a vital sign or a lab value. So what is the baseline? Is this new hypertension, new increase in blood pressure? Can I explain it with things like pain or anxiety, or is this something deeper than that? And so looking at that initially catches my eye, and then moving through the rest of the exam. So I would echo exactly what Pete said about the nasal bridge deformity. And then going into the lab, so and this again kind of piggybacks off of what Pete mentioned in the first aliquot, which is that it looks like we're seeing a mixed, potentially nephritic versus nephrotic syndrome, and then this sort of makes it look much more likely to be nephritic syndrome because the sort of threshold for nephrotic range proteinuria isn't met in the result of the protein to creatinine ratio. And anytime I'm sort of confronted with hematuria, so again, this is a good example of a case where you start off with a framework, and in this case, it was peripheral edema, and now we're adding a second framework and approach to that, hematuria in this case. So when I'm approaching hematuria, kind of the first question that I want to know is this bleeding coming from the glomerulus or the glomeruli, or is it non-glomerular bleeding? That's really the first branch point, and it does require looking at the urine sediment to help figure this out. So Pete mentioned RBC casts earlier and the fact that they weren't mentioned here. that would definitely indicate a glomerular source of bleeding. And then in addition to that, we look at the shape of the red cells. So in the framework for hematuria, it's glomerular, and that's things like glomerulonephritis or minimal change disease, outports, that kind of stuff, versus non-glomerular. And under non-glomerular, it's kind of an anatomic approach. So it's coming from the kidney, things like, pyelonephritis, renal infarction. Then next would be ureter, so things like nephrolithiasis or urolithiasis in that case. Next would be bladder, so things like bladder cancer, and then urethra, so urethritis, and then prostate would also be another structure in there that can cause hematuria, so BPH or prostate cancer, something like that. So the first step, though, is looking at the shape of the red cells. If it's coming from a non-glomerular source like the bladder, we would expect those red cells to be isomorphic when we look at them under the microscope. If they're being squeezed through a glomerulus, especially one that's inflamed, like it is in glomerulonephritis, we would expect that red cell to become deformed as it squeezes through. And you get acanthocytes and other deformities. Like acanthocytosis is sort of the classic like Mickey Mouse ear appearance of red cells. Those are acanthocytes. And so we look for dysmorphic red cells versus isomorphic to help us differentiate, as well as RBC casts. So I would be interested in more of that information, but so far we're definitely leaning towards something like GPA, a small vessel vasculitis that's giving rise to nephritic syndrome and the rest of this story.
Any Nate, did you want to take us to the next aliquot?
I sure will, and I will just say this is so fun and exciting to hear you guys say. We had some questions as you all were talking, both Andre and Pete, about dysmorphic red blood cells as well from the folks watching, and it's very rewarding from my side because I was trying to figure out which aliquot to put this information in, but we'll get it here in aliquot 3. So at this point in the case, nephrology was consulted to spin the urine and look at the urine sediment and for further evaluation. The urine after spinning did show red blood cell cast with dysmorphic red blood cells. That's correct. We're going to have a lot more tests coming through here. And so she had a hepatitis panel that was non-reactive. Her complement, both C3 and C4, were 131 and 24 respectively, which were within normal limits or normal. Her ANA was non-reactive. Her A1C was 5.4. HIV was negative. She had an SPEP with serum-free light chains that showed elevated light chains with a normal ratio. Her ASO, or anti-streptolysin, was negative. Her anti-PLA2R antibodies were negative. She had some additional imaging with a CT chest to evaluate, which showed clear lungs and no evidence of pulmonary nodules, granulomas, or infiltrate. And before I get into aliquot 4, an ANCA was sent and was pending results.
Yeah. Yeah, that's great. So I think reinforces again this idea of anticipation. And, Pete and I talk about this not infrequently, where we feel like medicine these days is moved in a direction where people kind of employ this shotgun approach to ordering labs and tests and imaging and we really find that can be a wasteful way of practicing medicine and we always try to stick to resource utilization and really trying to order what is necessary and so we anticipate what might be abnormal and what we would want. I never order a test without having some idea about what it might show that could help me and move the case forward diagnostically or therapeutically. And so I always try to keep that in mind. And with something like glomerulonephritis, I think it actually is one where maybe sometimes the history and the exam can really pinpoint, one entity. And I think we actually, potentially have a decent example of that here with this case. But it is one of those things where I think it is serologically driven, as Pete mentioned earlier. So whenever I'm faced with glomerulonephritis, I think ordering C3 and C4 is helpful because there's a differential in which the C3 and C4 are low. And then there's, an ANCA positive arm of the framework. There's an anti-GBM arm of the framework. And then there's kind of an other arm of the framework where things like HSP or IgA vasculitis hang out. And so I think it's totally reasonable to have ordered, that panel of studies. And, sure enough, some of the things that we were anticipating turned out to be positive, like the dysmorphic RBCs or like the RBC casts. Um, and then, I think the chest imaging is helpful here because, as Pete mentioned earlier, some of these small vessel vasculitides present as like a pulmonary renal syndrome, and GPA is certainly one of those. In which case, you might get little cavitary lesions, and they might present with hemoptysis in addition to kind of AKI, hypertension, and hematuria, and like a GN picture. Um, and yeah, I think I'll pass it on to Pete.
Okay. So again, I think oftentimes we order so many tests because some of the tests just take so long to come back. If we could order a test, get it back right away, then we could go step by step. So in this case, I think going back to this mnemonic that I use, which again, it's not perfect, and no mnemonics are perfect in real life, but on boards type tests, they generally are. When we look to see that the complements are normal, then that would seem to make lupus less likely. So the ANA is negative. It would seem to make post-infectious less likely the ASO was negative. Membranoproliferative also oftentimes associated with hepatitis C, that was negative. And Nate, did we have cryos on there? I can't remember if you'd mentioned cryoglobulins. But again, we'd expect the cryoglobulins to be negative.
They were negative. I don't think I mentioned it.
Okay. All right. Yeah, and usually, yeah. So and at our institution, we send out cryoglobulins to a lab in another state, and sometimes it takes so long to get them back that we use as a surrogate a rheumatoid factor and complement levels. You'd expect a low complement and positive rheumatoid factor, and we use that as a surrogate for cryoglobulin. So again, back to our initial hypothesis that this seems to probably be a vasculitis, like an ANCA-associated vasculitis. You would expect the complements to be normal and the preliminary workup for the low complementemic nephritis to be negative, which is what we're seeing. So I think I'm really waiting to see what the ANCA is going to show. My assumption would be that it would be positive, and then you have a choice of a C ANCA or a P ANCA, and I'm guessing it would be a C ANCA that would be most consistent in this case.
Dr. Sullivan, if you didn't mind, could you share the mnemonics which you shared with us in the chat for the people who are going to listen to this episode and not necessarily have joined?
Absolutely. So this is a mnemonic. Actually, you never know when you're going to learn something. I learned this on the interview trail when I was a medical student back in 1994. I went to actually Virginia Mason in Seattle, and they had a case conference where they had, I believe it was a nephrologist giving a conference, and he mentioned this mnemonic, limp cries for low complement in the setting of nephritis. So L for lupus, I for infectious or post-infectious, MP for membranoproliferative, CRY for cryoglobulinemia, and then he actually mentioned something called shunt nephritis, and you can develop nephritis in the setting of an infected ventricular peritoneal shunt, so something that's quite unusual. For normal complement, the mnemonic was GRAVE, G for antiglomerular basement membrane disease, R for RPGN, A for Alports, V for vasculitis, and then E is etc., meaning everything else, but the main cause would be IgA nephritis.
Wow, that's wonderful. Thank you so much.
Sure.
Awesome. And then the next aliquot that I have will share the diagnosis before I get into the fifth aliquot, which will just be further care. I did have a quick question for you too, because when I was seeing this case, I was also very much so like both Andre and Peter saying, I was very much so thinking that this is very likely a vasculitis. But one thing that kept eating at the back of my mind was we didn't have the ASO at this time. And as I mentioned, that mild blowing in the nasal bridge, it was very mild and difficult to see. And if that's what I was kind of hanging my hat on for a diagnosis of GPA or an ANCA-associated vasculitis, I had a hard time ruling out the possibility of a post-strep or post-infectious glomerulonephritis just because of her history of having that infection. And so I'm just curious, as an open-ended question to both of you, how do you just wait for the test to come back, or how do you think through any additional tests or additional history you can get from someone to try and make one of those more or less likely to you while you're waiting for these tests to return?
I think you're right to think about that initially because of the infection. I'm not sure if the time course quite fits. It's a little bit delayed, the 2-month time course. But I think, as you said, it certainly could be that, and I think you would be relying somewhat on serology. So either ASO, antistreptolysin, or the complements in my case, I think really helps out.
Yeah, and I would just add, I don't know, in my mind, when I think about PSGN or post-streptococcal, I usually think about post-pharyngitis and then it can happen with skin infections as well. And there's a little bit of a difference in terms of timing. I want to say the uh, pharyngitis, it's like synpharyngitis, meaning the GN kind of develops at the time of the infection, and the skin is usually delayed by about a week or two. But I agree with Pete, 2 months is definitely delayed. And I could be wrong, but I'm not as familiar with it following like ear infections. And then going back again, we actually just had a case of GPA on service a couple weeks ago. Pete will remember because as I mentioned to you guys, I'm always telling him about, the good cases or interesting cases, and we're bouncing ideas off of each other. So we just had a case of this, and one thing we did was ask retrospectively now about maybe that nasal bridge deformity and maybe about like sinus issues. It turns out that our guy actually was having recurrent sinus and sinusitis or sinus infections going back, months to up to like a year or so. And so, that you could do that too, Nate, to help kind of tease this out. Has this patient been having sinus issues for a while? Try to help you sort it out that way. But I also agree with Pete that the serology being negative is pretty reassuring too. And so.
Awesome. Thanks, y'all. I really appreciate that. It was something that was kind of irking me on this case, trying to figure that out. Well, I'll jump into aliquot 4, but before I get to the test results that'll kind of lead us to our diagnosis, I'll just share some additional history to talk about the questions that you were talking about, Andre. She did mention when we talked to her about this nasal, the bridge that had this slight depression there, she said that it had just started about 6 months ago, and she had just attributed, she thought she was just getting older and it might have been a normal thing of aging. She wasn't sure, but that she thought something was happening with her nose and it wasn't there. So it had been fairly recent that it was happening. There was no profound history of recurrent nasal infections, but in aliquot 5, I'll talk a little bit more about that as well. So without further ado, the results of her ANCA testing did come back, and it was positive. Her PR3 ANCA, or previously C ANCA, was positive at a 1 to 640 ratio with a 640 titer, pardon me. And then I had seen in the chat, maybe you guys can talk about this a little bit, but we did pursue a renal biopsy at this time as well to see if it was there. And it showed posse-immune crescentic glomerulonephritis, tubulointerstitial inflammation and injury, likely secondary to that, and some mild arterio and arteriosclerosis, but with about 18% fibrosed glomeruli within her kidneys. And so I'll leave it up there to reflect on that, the final diagnosis, as mentioned, of GPA.
Yeah, I think it's all consistent with GPA. So when I think about the ANCA-associated vasculitis, of course, there's the big three. There's GPA, there's EGPA, and there's MPA. The way EGPA is taught in the textbooks is that generally it only occurs in people that have a history of asthma and generally about a decade worth of asthma. And then they develop a second decade of peripheral eosinophilia before they then can develop the EGPA. Unfortunately, in real life, it doesn't always happen that way. I've seen cases where people do not carry this history of long-standing asthma and eosinophilia. And the ANCA in this situation may be positive or could be either C-ANCA or P-ANCA. MPA is probably the most common of the three ANCA-associated vasculitides. So there's no G in the name. So on biopsy, there's no granulomas. And also to distinguish it, I think it's something that generally has more renal, less upper respiratory findings. So the upper respiratory findings, I think, are something you generally see much more in GPA versus MPA.
Yeah, going back to the earlier question about the infection and whether it's playing a role, who knows? I mean, who knows what GPA really is and what triggers it and what doesn't trigger it. I saw a case with like autoimmune conditions and stuff. The immune system's an interesting organ and beast, and sometimes infections do trigger autoimmune conditions. I mean, we see it more explicitly with things like ITP or PSGN, that kind of thing, but. I saw a case of a young woman who presented with H. flu bacteremia and had epiglottitis. She was unvaccinated. She was 19 years old at the time. And she then developed, while she was hospitalized, she developed acute pancreatitis. And then she also developed hematuria. And, it was sort of like, why would these things all happen? Like, this is strange. A young, otherwise healthy person coming with H. flu epiglottitis and then develops pancreatitis in the hospital. Well, when I went to see her in the morning, she had a classic malar rash. And then, you get retrospective history from her, and she's been having a year or two of arthritis and joint pains and morning stiffness. And sure enough, she had, an underlying lupus, and she had developed lupus nephritis. And about 10% of patients with lupus develop like an autoimmune pancreatitis. And so that kind of like put it all together. But then it's sort of like, okay, did the infection play a role here? Did it serve as like a trigger of an acute flare of lupus that unmasked it in a way? And so yeah, so it's possible that in this case, maybe that infection that this patient had somehow triggered her immune reaction that either unmasked or kicked off a GPA like picture. So who knows? But yeah, I think the rest of the aliquot there, yeah, does seal the diagnosis. And there was a question in the chat that I just saw, so I didn't get to it at the time. But the question was, would we have pursued a renal biopsy now prior to when the ANCA had returned? And yeah, I'd be interested in Pete's thoughts on this too. But I would say. Probably. I mean, time is tissue when it comes to like, neurology and strokes. And I would think of it the same way when it comes to like a GN. I would want to try to preserve as much renal tissue and parenchyma as I could and not allow this thing to go on longer. So if I could speed up the diagnosis and get this person, the steroids and the immune modulating or immune suppressive agents that they need earlier than later, I would really try to pursue that. And I think you have so much info that's going for GPA even before the ANCA returns that I probably would go for that. But I would be interested in Pete's thoughts and then also what a nephrologist would say, because of course you're going to have your nephrology colleagues on board here and they'll help drive that decision too. But Pete, what do you think?
Yeah, I would ask the nephrologists if they felt that we had enough information here with their history and the serologies where a biopsy was actually necessary. That would be my question for them.
I wonder if a biopsy would also have like a baseline biopsy of their disease would help later on, potentially if like they weren't responding or just to kind of see if there's a response later on. I wonder if they would always want like a baseline biopsy, but I don't know. It's a good question.
I had one question for both of you. Could the seronegative migratory polyarthritis, I mean, that's what her past medical history could it have been the initial presentation of GPA and it was just that the fact that the GPA was not diagnosed for so long? Could it be that?
It's a great question. I would want to know more about how it presented. So all we know is that she's got the seronegative, what is it, arthritis, or what was the presentation?
Polyarthritis, yeah.
Oh yeah, absolutely.
Yeah.
Yeah, I mean, most of the seronegative spondyloarthropathies, for example, like psoriatic arthritis or ankylosing spondylitis or enteropathic or those things usually are oligoarticular. I mean, it doesn't mean that they can't be polyarticular, but the vasculitides can present with a polyarticular arthritis. So, I mean, it's absolutely, I would probably say yes. And leaning on Occam's razor, Pete and I always try to explain things with the simplest explanation or one etiology explaining multiple. things. And in this case, I would lean towards that and say Occam's razor probably was, yeah, undiagnosed GPA at that time.
I will tell you from my perspective, and then I'll jump into aliquot 5, that in reviewing this case again in preparation for this, the recent rheumatologist would also agree with you that the time course kind of aligned, that they think that likely her previously seronegative polyarthritis was early manifestations of her GPA that we just hadn't seen.
I just had a case of a young woman, 42, I want to say, who came in with, she had a history of pseudotumor cerebri and had a VP shunt, and but was otherwise healthy, and comes in since her VP shunt was placed, like she's maybe some of her symptoms went away, maybe it's kind of come and gone since then. And she presented to us with neuro symptoms, numbness and weakness in the upper extremities, and some vision issues. And we ended up doing an LP, and she had a pleocytosis, and she had some abnormalities on her brain imaging as well. And it looked like more of like a multiple sclerosis. Her optic nerve was involved and other cranial nerves versus like a neurosarcoidosis or something. And our thinking was actually it was the intern on our team said, you know what? I bet that pseudotumor cerebri was probably was probably misdiagnosed as that, and it was actually the current process, either the MS or the neurosarcoid. And I love that line of thinking, and I think she was totally spot on to think that. That kind of reminds me of this in a way.
I think that probably happens quite a lot in the hospital. Misdiagnosed things we think we're certain all the time, but once we take a look back after a few years, figure out what's actually going on. Okay, I'll finish it up. Just that this aliquot 5 is mainly about what happened after her hospital course. And so during her time in the hospital, actually before we got the results back for the ANCA or from the renal biopsy, nephrology was so concerned about this being an ANCA vasculitis that she was initiated on rituximab inpatient, and she started a prednisone, a high-dose prednisone taper, 60 milligram per day while inpatient, and then started on prophylaxis for that as well. Unfortunately, her creatinine initially continued to worsen, and she was readmitted a month later, requiring a right IJ tunnel dialysis catheter placed so that she could start dialysis. She started avacopan per rheumatology rex and got a couple doses of cyclophosphamide. And I will say, upon re-looking at the case again, with all of the interventions that she has received at this point, she just recently got off of dialysis and her renal function has actually improved. Creatinine's gone down to 2, and she's able to create urine better on her own now, which is great. Something of interest for me in regards to the saddle nose deformity that she had, it was very concerning for her. And so she was actually referred to ENT and plastic surgery for evaluation of changing that, of having plastic surgery to regain the integrity of the structure of her nose. And then during one of her ENT evaluations, actually, and this was not done in the hospital, but afterwards, they evaluated, as you were mentioning, Andre, looked up and did a rhinoscope, and she actually had a chronic stable septal perforation, likely from this chronic GPA that had been there for quite some time. Just other factors for the case that I just wanted to mention is that she fits the age demographic of a 57-year-old woman here, kind of a middle-aged adult. And she had the concurrent arthralgias, which we can see in 80% of cases. And as you had all mentioned, likely predated her presentation here as well. And then the one thing I wanted to point out that we'd spent a lot of time talking about was the difficult differentiation in this case between an post-infectious glomerulonephritis versus this ANCA-associated vasculitis. And so I thought it was a pretty cool case. I don't know if anybody has any reflections there. I love the problem representation that somebody pointed out there as well.
I want to throw in something I learned from Jerome Kassir, who's the former New England Journal editor. He wrote a book back in I think it was in the late 80s or early 90s on learning clinical reasoning. I think it's the title. I looked for it on my shelf, but I think I loaned it out to someone. And he talks about when you're considering a diagnosis, then one way to double check your answer is to see if it meets certain criteria. So first is the diagnosis coherent? Does it make sense that this person would have this disease? And I think in her case, you could say, yes, 57-year-old woman with a history of some sort of autoimmune disease. It makes sense that she could have this disease. The most important is is the disease adequate to explain everything? And in this case, you want to explain almost everything that happened, her ear infection, her nasal bowing, what's going on with her joints, what's going on with her urine, what's going on with her labs. And I think you could say, yes, all of these could be explained by GPA. And then the last one, is it parsimonious? And that gets back to what Andre was saying about Occam's razor. You don't have to come up with a second or third diagnosis. Everything could be included under this umbrella. So I find this to be really helpful if I'm considering a diagnosis. Double check to say, does it make sense in this case that all these things fit?
Wow, it's such an amazing discussion. And then so glad that Nate could put it together and bring it for us. And when we're speaking about the physical diagnosis and what to be aware of and see what's fitting, I just got reminded of one thing which my grandmom told me when I chose to do medicine, was that apparently there was this, she's from a village back in India. And she said there was this neighbor of hers who had very severe headache, and they had spent a lot of money, like there's zamindars, so they spent a lot of money trying to find out why she was having the headache, and she underwent all kinds of biopsies and tests, and they were all negative, and people didn't really know what was happening with her. And there was this one doctor from the city who came in and then told her to take away her nose ring. And then in back in India, they wear these nose rings, and it was like huge diamond nose ring which she was having, and apparently that was reflecting the light into her eyes and was causing the headache. So, so she said you need to be like a doctor who does the simple solutions and not like the ones which is doing all the investigations. So I just got reminded of that and thought I would share that.
Absolutely. She's a brilliant woman.
Nate, did you want to take us home, like to share with us what were your takeaways from the whole, I mean, taking care of this patient? And after that, also, I would love to hear Dr. Sullivan and Dr. Mansoor share something which you want us to remember from this whole hour.
Yeah. I had mentioned these a little bit before, but I think the biggest takeaway home, the takeaway points for me were in relation to history and the patient's epidemiology. So, does this patient fit the type of pathology that I'm thinking about, and just how much information you can get from the history? I think if we kind of look back on this and we can see everything that's outlined in red here, so changes to the nasal bridge, brown frothy urine, lower extremity swelling, and then we see somebody has dysmorphic red blood cells in there, you can almost make the diagnosis just from a little bit of information and from the history that fits in with that pathology, which is something that I really liked about this case and thought it was very cool. The other thing, the only other point that I'd like to make, which has already been said, but is really nice to say, is it's always good to go back and re-review the case and see if any previous symptoms can be attributed to the pathology that you're seeing here. And so taking the time to maybe delete some things out of your structured thinking about this and relook at the case. So for this instance, say, if we say she doesn't necessarily have a seronegative arthropathy or something like that, but just say, oh, let's reclassify that as a polyarthritis that's been coming and going now that we don't know anything about. I think it fits very well into the framework here for a GPA. So those are my two big takeaways from this case. I'll pass it off to Pete and Andre as well.
Andre, you go.
Yeah, no, I totally agree. And I think, one of the takeaways for me would be, just as Nate mentioned, constantly going back. So I tell my students and residents this all the time, is it's almost never a one and done approach for me when I go and see a patient and talk to them and take their history and examine them. I almost always, especially in cases where there's diagnostic uncertainty, it's almost like multiple trips, usually 2 or 3 trips back. I go back to my desk and I'm thinking, and oh, I'm starting to create my framework and my differential and my hypotheses. And oh, I didn't ask about, this, or oh, could the brown urine be hematuria and the frothy urine be proteinuria? Let me go back and ask them some additional questions or examine them in a certain way. So it's always, a back and forth. And so that's this case is a good example where I could have seen myself doing that, going back and forth, gathering more history as data starts coming in, getting more history, getting more exam, getting more data, not a one and done approach. And Yeah, the other thing is again, it does remind me of that case that I recently saw where, yeah, this sort of diagnosis in the past was probably better explained by the current diagnosis. I think that's a neat little feature of this case. Those are my big takeaways, and just again, remember to anticipate. That's a principle I learned from Pete, and it serves me so well in medicine. I always try to anticipate what I might see or hear or feel or the results of tests that I'm ordering. Always try to anticipate. That's really critical in medicine.
I'm not sure how much more I have to offer, except that I think most diagnoses can be made just from the history alone. So I think just the history in this case really was pointing in one particular direction. The exam also helped reinforce what we'd already come up with just from the history, and the labs just confirmed what we really thought was going on. It's not always that way, but you really need to have a very thorough, complete history in most cases.
Thank you so much, everyone, for joining in. For now, we've passed 1 hour, and to just be mindful of everyone's time. And thanks, everyone, for also being very active on the chat. And you've got to check out Dr. Sullivan's and Dr. Mansoor's book. They're very good. And Nate, we are waiting to see your podcast come up soon again. So I'm going to stop the recording and then wish you.